Well, this is the natural history of Hodgkin's disease, at least when I started in the field of, in this field at the NCI, where people in those days were allowed to apply for a commission in the U.S. Public Health Service and work at NIH. And it was a great privilege, and it was halcyon days of early clinical trials in malignancy. The disease was selected both by Tom Fry, Vince DeVita, John Moxley, various colleagues of mine. It seemed to be the disease that might be more vulnerable to combination chemotherapy, analogous to what we saw with childhood ALL, which at that time was beginning to be cured with a regimen called PUMP or VAMP at that time, which Jay Freireich and Tom Fry were pioneering. But this was a published survival of Hodgkin's disease, as most series had indicated. But on the other hand, there was a level of vulnerability of the disease to a variety of single agents, which you see here. Not a whole lot, but there were some drugs that we could use at the time for a disease that we really thought in advanced state, most of them were in advanced state, was a fatal disease, and justified the use of a fairly aggressive chemotherapy. And the first regimen that was developed, there was several developed, was MOPP, and then followed by MOPP with the availability of procarbazine. And the interesting thing was that these patients had big toxicity from it. It was not easy to give it. We didn't modify the doses very much, certainly not vincristine, but the early evidence was that these patients were getting remissions, and these remissions were durable. And this was the single drug activity of these agents. It wasn't very much, but in combination, it showed that they were better. And that's sort of the kickoff for combination chemotherapy, at least in adult cancer. We had already appreciated some of that in childhood leukemia, but this was in a sense a kickoff for that. An interesting spin-off of all of that early MOPP experience was that a modification of MOPP called CMOPP with cyclophosphamide we used for non-Hodgkin's lymphoma, large cell lymphoma type, and we showed that it could actually cure that disease as well. Diseases that we knew nothing about their biology to speak of, but were still potentially curable. The same was analogous to Burkitt's lymphoma that you saw that picture in that Uganda unit that was funded by the NCI at the time. This is the long-term survival, I mean long-term survival, disease-free survival of patients treated with MOPP in those early NCI days. This slide was, and this data was provided by Dan Longo, who worked at the NCI for many years before he became an editor of the New England Journal. Anyway, this is the durability of those patients who were so treated. And this is just disease-free survival, not event-free survival, because people get sick and die of other things and have complications of chemotherapy, et cetera. But in terms of recurrence of disease, this is what this slide shows you. It was replaced by, in a CALGB trial that I chaired, compared ABVD to MOPP, and ABVD was equivalent to MOPP in that trial in terms of survival, but it was a far easier regimen to give. I don't know who's going to get credit for its development, but the Italians had pretty much assumed that they did. And Bonadonna and probably some early CALGB trials all indicated that these drugs had activity independent of the MOPP regimen. And this was a much easier regimen to give people because of the lack of second malignancies, especially leukemia that we reported with MOPP, and all of the side effects that we saw with MOPP, including sterilization, and ABVD didn't even do that. So it was a far easier regimen to give, and was really the kickoff, that study that was a CALGB randomized trial, to using ABVD with or without radiation for patients with earlier disease because of the lack of long-term toxicity. And this was the trial. At the time, there was a publication that suggested if you gave MOPP and ABVD for 12 cycles, which was very toxic compared to ABVD and MOPP. And this is the study that we published, some years ago. As you see, it was CALGB 82, that was 1982-51. And that was the trial that showed that really you did not shortchange the patient by avoiding the MOPP regimen. My colleague Vince DeVita never forgave me for this study, but there was dose de-escalation provided in the protocol because of toxicity, something that we really did not do very much at NCI. And when you start modifying doses of toxic drugs, you may not get the same responses that you saw if you didn't modify the doses. And this is, for those of you who are familiar with the escalated BEACOPP regimen, can understand that standard dose BEACOPP was no better than ABVD. They had to escalate the doses to get something slightly better than ABVD, but at the price of an enormous toxicity. This is the, I try to put this slide together, this is the efforts that places, institutions, groups have made to develop combination chemotherapy for Hodgkin's disease. All sort of justifiable efforts to try to improve and maybe find less toxicity out of regimens. A lot of it being, I think, attributable to institutional or group chauvinism to find that they can do something better. But unfortunately, really, they have not. And that goes for, in my view, escalated BEACOPP. And so we're still with ABVD, with the exception of the pediatricians that you heard earlier with their different regimens. Most of us are now relying on ABVD, at least in the average patient outside of a clinical trial. The questions in advanced disease, and you heard much of this already, and that this is repetitive, can one say that ABVD is the standard regimen that that everything has to be compared to? And I think we're down to saying yes. Is there any role for radiotherapy in advanced disease? Maybe. Are there anything more intensified regimens, such as Stanford 5, all of them respectable anti-Hodgkin's regimens, BEACOPP, the British Clavip-Eva, superior to ABVD? Well, in randomized trials, none of them have been shown to be better in terms of overall survival. Progression-free survival, yes. If you intensify chemotherapy in any drug-sensitive disease, whether it's testis cancer or leukemia or whatever, you're going to have a better progression-free survival. You may not have a better overall survival. And that's what these the randomized trials in the Stanford 5 and BEACOPP for that matter, and Clavip-Eva have shown. Will the potential for greater toxicity justify their use? And that is something that comes into both ethical and medical judgment decisions in facing a patient. Can the salvage of ABVD relapse enhance the benefit of, balance the benefit of the more toxic regimens? And I think that's what's happened. There's data now, that really good data, from places that focus on transplant to show they cannot effectively, as effectively, salvage patients who fail escalated BEACOPP, for example, compared to ABVD. And that is probably the essence of the difference between them and why there is no difference in survival. So you can balance your toxicity, you can balance the efficacy, and make your choice. But I think in most circumstances, people would choose the least toxic and effective regimen as initial treatment. I don't think that has changed very much. In localized Hodgkin's, there are issues, and you've heard them again. Combined modality was very successful, but there was a problem. And you've heard the problems. I know David Strauss has been a great advocate of concern about the toxicity of radiation or the efficacy. And this is just one plot of data of cardiovascular and neoplastic combinations of patients who get combined modality compared to chemotherapy alone. And there's series after series after series that have shown this. But you see, you have to wait 20 and 30 years. And those of us who've been around for a while can attest to the fact that these late toxicities have appeared, and they're fatal toxicities in many cases. So that has led really to the effort to abandon radiotherapy where we can. The best bioassay that's come along, we all know, is now the PET scan, which has a very marked sensitivity and great specificity for Hodgkin's disease and many other lymphomas. And we use it avidly in assessing the benefit of any treatment in that disease. There are still questions in localized Hodgkin's disease that some people have continued to raise. What is the minimal amount of chemotherapy that you need? And it's getting down there to 2 or 3 cycles of ABVD, and if you go PET negative, maybe all that you need. The long-term toxicity of ABVD alone there's been very few studies in that area. One can accept that there may be some cardiac toxicity with adriamycin, and there's some toxicity with bleomycin, but you heard already the Rathel study that bleomycin is fading rapidly from a vital role in the management of this disease. And some years ago, maybe Mort remembers, I reviewed the data, the CALGB database. I asked them to give me all the patients, the survival of all the patients who received 6 cycles of ABVD full dose versus those in whom bleomycin was dropped for any one reason. And the survival was the same. And we speculated in that report that bleomycin might not be necessary for the long-term benefit of Hodgkin's patients. I think we're getting there now with scientific studies. Bulky disease is reduced to a CR with a PET. Does it need radiation? It's being studied. I think Anne Lacase is doing a trial with a group trying to ask this question. There's data that was presented at ASH just last year that suggests, from Vancouver, that suggests that in bulky disease that becomes PET negative, you don't need to radiate. And I think with some randomized trials and some publications of their experience from Vancouver, because it's only been an abstract, might start raising questions about the need to radiate a patient who may have been bulky, but who had marked drug sensitivity with PET negativity, that you could spare them the risks of radiation therapy. Biologic prognostic factors are another question which may predict for relapse from chemotherapy, such as CD68, which is a macrophage marker that is associated with a slightly less survival than the CD68 negatives. But there are a host of gene aberrations that have been studied, especially in large cell lymphoma, but also in Hodgkin's disease, that might contribute some information as to the likelihood of somebody to relapse after a thorough, complete remission. And that is a moving field. What we've come to now, and you've all probably heard them in many trials, that how many cycles of ABVD prior to the PET negative, various trials, I just outlined them on this slide, and you see it's 2 or 3 cycles of chemotherapy after 2 cycles of ABVD probably is all you need for the vast majority of early disease that's not bulky, in my opinion. This is a progression-free survival. I show it because it was not a controlled trial. It was a retrospective review of our data. Both Jeremy Abramson at the MGH and I put all the cases together of patients who received, in retrospect, chemotherapy only for localized early Hodgkin's in people less than 45 years old, younger patients, and who got chemotherapy. They got 4 to 6 cycles of ABVD for localized Hodgkin's in those days. And this was the progression-free survival curve. And I show it because the radiotherapy establishment took great, were very unhappy with the conclusion that you could probably get away without radiating early Hodgkin's disease. And that was really before now randomized trials are showing up from Canada, from a number of places that have shown that in early Hodgkin's that goes into remission with PET negativity, you don't need radiotherapy. And that is history that's passed. But as I say, I had to debate radiotherapists on the basis of this data, and I think I lost in most of the debates because it wasn't a randomized trial. This is the randomized trial from Canada that I started putting nails in the coffin of radiotherapy, and or the other way around, that showed that chemotherapy alone could do well, because in this trial, many of the patients on the radiation side got subtotal nodal radiotherapy, which we don't do anymore. These are regimens from the literature that were compared to ABVD, and not a one of them showed a survival advantage. And and the analogy here is some of those regimens that I showed you earlier that came out of institutions or groups that were an attempt to improve on the ABVD side. But despite all of these, and these were randomized trials, not a one of them showed at least an advantage for the patient to live a day longer. Again, the long follow-up is not there. The follow-up is sometimes 5, 7, 8 years. But on the other hand, late relapse from Hodgkin's disease is known to occur, but it's really quite unusual. Somebody showed this slide earlier. This is the IPS. It's gotten better. This is data from Vancouver, where they do very careful analysis of their patients. And if you can remember the old ILS scheme, what this suggests is things have gotten better. But not only that, your highest risk patient has a survivorship of almost 50%. And so that if you were a statistician having to design a trial to try to beat that or show something better than that, you'd have to be up against the fact that half the patients are cured by standard therapy to begin with, in the worst prognostic group, which is really not very common. The microenvironment of Hodgkin's disease has really been the scientific new kid on the block. The microenvironment is fascinating. The Reed-Sternberg cell, as you know, is a transformed malignant B cell without the features of a B cell, but it's basically can be summarized that it's a cell that relies on the surrounding lymphocytes to live because of the interaction of receptors and on the surface of the Reed-Sternberg cell with factors on lymphocytes, such as CD40, for example. And that interaction fires off NF-kappa B reactions within the Reed-Sternberg cell, which are anti-apoptotic and pro-proliferative, if you will. So that the malignant cell puts out feelers, cytokines, that attract lymphocytes. The lymphocytes then surround the Reed-Sternberg cell and feed it, keep it alive. Enter the immune therapy problems coming up. This is a scheme, this is a cartoon of the interaction of various cells, normal reactive cells with the Reed-Sternberg cell, and it's fascinating to understand how it protects itself against immune attack, being surrounded by lymphocytes, and how it actually lives off of those lymphocytes at the same time. The gene profile of Hodgkin's disease is shown on the far left compared to non-Hodgkin's lymphomas. Distinct differences. Certain genes are mutated in Hodgkin's disease that are not seen in the non-Hodgkin's lymphomas. There are some similarities with Hodgkin's signature and primary mediastinal non-Hodgkin's lymphoma. they probably share some progeny or really origin together. The immune escape story is really evolving, and you've heard much of it probably and read some of it probably. There are two, at least we know, for Hodgkin's disease. One is galectin-1, which is the work of Margaret Shipp at the Dana-Farber. And there is still an effort to develop a monoclonal antibody against galectin-1, which is one of the ways the cell protects itself, the malignant cell protects itself against immune attack. And the PD-1, PD-L1 story, which again, part of it is a Dana-Farber story because it was sort of invented in part by an investigator at the Dana-Farber. Also, some of the early reports of the activity of the immune blockade inhibitors also came from our colleague Philippe Barmond at Dana-Farber. This is a cartoon that just says it. On the left side is the mechanism when it's working, and on the right side, it's when the antibody is being given, the antibody being either nivolumab or pembrolizumab, and there'll be several others coming along. This is PD-L1 expression on malignant cells of Hodgkin's disease. The work of Margaret Shipp at the Farber showed that amplification of chromosome 9p24 was associated in most all instances with very marked elevation of PD-1 expression in the Hodgkin cells, which in a sense set them up for the inhibitors, the activity of the inhibitors. Now, in my view, and as you can see here, it's about 87% response rate. Compared to other lymphomas, it's really much higher. It's like releasing a team of wild dogs. These lymphocytes, once you prevent the malignant cell from defending itself, these lymphocytes are all surrounding it. And it probably is going to be the disease in which the quantity of the response is the greatest, in my opinion. Although there have been some really fascinating responses seen in the melanoma experience as well, and some other solid tumors have this activity. But Hodgkin's was really quite high, and some of those responses are really lasting a long period of time. The immunophenotype of the disease is shown here, remembering that lymphocyte nodular predominant is really, in my view, more closely related to B-cell lymphomas than Hodgkin's disease. And the CD30 was, as many of you know, the reason for developing an immunotoxin. But it's also a fact that the antibody against CD30 by itself had no activity with Hodgkin's disease, despite the fact that CD30 is rich on the surface of these cells. It remained for a development of an immunotoxin, which is now brentuximab vedotin, also has another name, but and that showed that it could be taken into the cell and that the toxin would do all the work of killing the cell. The problem is that the toxin is not metabolized. It's released from the dying cell and then circulates and becomes a neurotoxin. And that's one of the problems that we see with brentuximab. There are probably other immunotoxins coming along that might be less neurotoxic, but equally efficacious in Hodgkin's disease, as we think that's going to happen. And so the efficacy of this regimen, this drug as a second-line regimen, as a salvage regimen, is well known. What we don't know yet, because there is a big randomized trial of over 1,000 patients of comparing ABVD to AVD plus brentuximab. You can't combine bleomycin and brentuximab together because of serious pulmonary complications. So bleomycin was dropped, and nobody was sad about that. And they substituted brentuximab. That is an important randomized trial from the point of view, more, I think, from the manufacturer, but if you can use it up front, and if it does discourage relapse, it will save money because the salvage of Hodgkin's disease, although efficacious, is expensive. And so it will have to save enough patients to justify its cost and its toxicity. But we may see that. This is some data on the long-term follow-up of those patients. We can eliminate that. One of the problems is that there haven't been, at least when I put this slide together, a lot of randomized trials in localized and advanced disease in North America. And outside of this country, you can see the differences. And that may be a reflection of just the health care system, the size of the United States, and many other factors that we don't even recognize. But certainly, we have not been that prominent, given we have 300,000 people in this country, in establishing new facts about the treatment of Hodgkin's disease. We're okay about innovative changes, whether it's nivolumab, whether it's brentuximab, or you name it. We're, I think, leading the world in that. But when it comes to testing it and getting it tested promptly, we're not as good as some of the European countries with their, let's say, more organized health systems, which I'm not advocating at the moment, but perhaps that may be the explanation. Well, finally, what have we achieved? There's Thomas Hodgkin, who himself was a failure. He applied for a job at Guy's Hospital, and because he was kind of an outspoken character and offended the stiff British establishment, he didn't get the job. And then he eventually became kind of an associate of Sir Simon Montefiore, traveled with him. And the poor man died of typhoid in Palestine, then Palestine, and he's buried in Jaffa, and actually a churchyard in Jaffa. But what we've achieved over the years, I think, is we've shown this to be now curable. We've, I think, recognized and are striving to reduce the toxicities, and we showed that they really can cure the disease. And whether or not it's going to be allotransplant or what that picks up some of those unfortunate patients who even fail autologous marrow remains to be seen. But it's been for me, it's been a very interesting and very exciting medical experience and professional experience. And I thank all of you for bearing with this talk, and I thank all of you who've awarded me this award. Thank you.